get ready to take control of your healthcare. Here's your host, Ray Kober.
We're live, ladies and gentlemen. Welcome to Broken Healthcare. My name is Ray Kober. I am your host, and I'm delighted to have with us today our guest, Robert Baird, the president of the National Cancer Treatment Alliance. Robert's work focuses on connecting independent oncology practices with self-funded employers to deliver the best cancer care at the lowest cost. We first crossed paths at the National Alliance, I believe, and we kind of picking up where we left off. So how are you, Robert?
I'm good, Ray, and thanks for inviting me to your podcast today.
Of course. I'm, again, delighted that you're here. So before we get into the serious stuff, and I don't know how much you could share, but I want to hear about your wife's work. I understand that your wife works on the B-21, and I'm a little bit of a UFO nut. Yeah. So can you talk to me a little bit about what she does?
Yeah, so she's the CFO for the B-21 program, and she's responsible for ensuring, the budget's complete, the program and the production is all on time, and that's probably about as much as she can tell me.
I gotcha. And after that, it's just like, hey, I could tell you more, Robert, but I might have to kill you.
Yeah.
So for folks that don't know, can you share a little bit about your background and how you started? I understand that you actually started your career in nursing. Is that right?
Actually, I started in health and wellness. So I started in health and wellness and corporate health programs back when that was big, back in the 80s. We did a lot of on-site screenings, a lot of preventive care programs, a lot of screening programs, really focused on the corporate health environment. And so that kind of morphed into occupational health, and that's when I looked at getting into the nursing aspect of it. So I got my nursing license from Excelsior College, and then continued just working in healthcare and continued working in the outpatient setting all through that. I've run programs in rehabilitation, physical therapy, and then also an ambulatory surgery center background too.
Wow. So you actually practiced as a nurse? You were treating patients, or not so much?
Not so much. I did about blood pressures and flu injections at some of our screening programs, but that was about it.
Okay. So you didn't get too deep into it.
Didn't get too deep into it.
I ask because I say it all the time. Like, I think nurses are just God's people. Like, it is a difficult, often thankless, occupation. And they do so much for their patients, and without them, they're really, I believe, the backbone of quality healthcare. And I believe we owe them all a debt of gratitude. So you didn't go down that road, and I don't blame you, because that's not for everyone. I think, and it has, maybe less to do with service than I almost feel like it's a calling. And if you don't have that calling, then, it's probably not for you.
Yeah, I agree, because, being around the nursing profession all my life, mostly in managing and support and, getting them in critical roles, particularly in oncology. Nursing is a calling. Oncology is a very tough nursing profession to be in, a lot of dedicated patient time, a lot of patients who are dealing with emotional issues, with a lot of health issues. They take a lot of care, you've got to really be on top of those patients to make sure they're getting the highest quality of life they can as they progress through their treatment journey. And so, sometimes that can be very tough when you have patients you get very close to, because you see them every day, a few times a week for months, sometimes years on end, depending on their treatment. So you develop that personal connection with those patients. And then when, they transition or, sometimes, do pass away, that's very challenging and very tough. So you're right, it is a very tough profession. And our oncology clinics, the nurses are so vital and so critical to the excellent patient care that we provide. I mean, it's just very, very important that you find good, high quality, very dedicated, compassionate nursing staff.
Yeah. So tell me a little bit about that. Did you transition from nursing into your current role? Was there something in between, or, what was your path like? And then, share with the audience what you're doing today and kind of what your mission is.
Yeah. So when I did a lot of the nursing back when I was in the corporate wellness piece, like the flu injections, the screening programs, then I started to manage those programs, and I left that to run a primary care office. So then I started to transition into healthcare management. And from that, I took on a role as the director of a surgery center. And then, again, continue working with doctors, nurses, focused on the outpatient setting. And then came into this role as president of the National Cancer Treatment Alliance. And our focus is really like you mentioned, connecting community oncology practices with self-funded insurers or self-funded purchasers, self-funded employers through a variety of ways, through education awareness, and then also the ability to enter into some contracting relationships to provide high-quality health care at a lower cost, or cancer services at a lower cost.
Yeah, because cancer is, you could correct me if I'm wrong, but I believe it's second only to heart disease as the number one killer in the United States, if we're talking about disease. And it's extraordinarily expensive to treat. And that's one of the issues, right? There's an affordability factor, and then there's also guiding care. So I'd like to expand on that a little bit, but in terms of your role, it's somewhat abstract, right? When I hear what you just said, president of the National Alliance, what exactly? And I understand you're kind of engaging oncology practices to facilitate a relationship with self-funded employers, and self-funded insurance makes up probably the biggest part of the healthcare ecosystem. Particularly on the commercial side, and commercial insurance is bigger than Medicare, Medicaid, TRICARE, all the government-funded programs combined. And so it's a huge marketplace. So I guess, a couple of questions. If you can kind of just expand on what the alliance is, and how do you go about facilitating that connection between the various practices, oncology practices, and self-funded employers?
Yeah, so the Alliance is a independent national network. It's got about 50 practices in it that are independent by nature. We have about 900 providers, and we actually are across 29 states. So it is a large organization, and we're structured as a clinically integrated network. And because of that, the practices can stay independent in their own markets with their own governance, their own operations, and then we are there to provide that any kind of additional support they have, additional things that we can provide to them. Like we're measuring some quality metrics. We're out, like you talked about, we're out looking for opportunities to connect those practices. So we've been working with some of the business groups on health, like where we met with the National Alliance, a very important organization in terms of the self-insured employer market landscape in terms of healthcare purchasing. We've worked with regional ones, the Midwest Business Group, the Economic Alliance of Michigan, Employers Forum of Indiana, all the ones that are connected to that. And those organizations are really focused on finding solutions for their employers. And we want to be one of those solutions. So we interact with employers that way through the business groups we work with, also through some of the brokers that we've met and work with. We're actually working on with a broker right now with a benefits advisor to develop more of a product that we can actually bring to market, where we've got a TPA, somebody who helps manage the network. So we're bringing that oncology piece to the healthcare continuum, to the puzzle.
Got it. Yeah, thanks for clearing that up. So, I think part of the, to just kind of frame this so that folks understand, because we, believe it or not, I talk to CFOs and coach CFOs and CEOs on a daily basis, and I'm always exasperated because healthcare is typically their number one expense after payroll. Yeah. If it's not number one, it's usually 2, 3, or 4, right? It's a huge expense.
And cancer is usually number 1 or number 2 in that now also.
There you go. And so the idea is we want to get them to a place where instead of just simply relying on their broker, and it's not a slam against brokers, but it is and it isn't, right? Because if you look at the marketplace, the huge giant brokers with the skyscrapers in Manhattan and Chicago and, et cetera, are either publicly traded or they're very large privately held companies. And if you are working with one of those organizations, there are most definitely benefits, particularly if you're a huge, company yourself or an enterprise organization, there are certainly benefits there. But I think with respect to the healthcare piece, they are managing that part of the business, not necessarily in their client's best interest, but in their shareholders' best interest. And that's the American way, right? I mean, no business is out there to make less money for their shareholders.
Exactly.
They're out there to make more money for their shareholders. But the issue is left, kind of on its own, just relying on your broker and your insurance carrier to manage this, you have very little opportunity for intervention. And when you look at that healthcare budget, 80 to 85% of it is claims. And so that's the piece that you really have to focus on. The administration, 15, 20 cents in the dollar. Yeah, I mean, you could certainly sharpen the pencil and find some shekels there. But really where the gold is the overspend and the waste and the fraud and the abuse. And if you're partnered with a broker that really doesn't have interest in fixing it because left the way that things are rolling, they're just making more money year over year, you got to put eyes on this. So how specifically does your solution, like if I'm an employer, we meet, whatever, at a country club or in a bar or at a restaurant or at a coffee shop, and we start chatting, maybe where our planes are both laid over, and I meet you for the first time, and you come to know that I have an organization and I run it and it has 5,000 employees. How would you describe to me how you might help?
Yeah, so I think the first thing we want to look at is kind of that they know what their organization is doing in terms of cancer care. Are they just treating it passively?
No, we're having a conversation. So ask me. Say, Ray.
Yeah. So Ray, are you treating? So how much do you know about the cancer care your employees are receiving?
Nothing. Zero.
Nothing. Do you know?
I do know that there are members that are suffering, with cancer and battling cancer. But I just, we have good insurance, and they're being treated by their doctors, and that's about the extent of what I know.
Yeah. Now, do you have anyone specifically overseeing any of those claims or monitoring what those claims are doing? Do you have any idea of where those services are being provided?
I'd be lying if I said that I did. We do have a very active HR team, and I know that they're there to assist. But beyond that, it's really out of my purview.
Okay. And then, do you know if you're providing any support services, or really what your providers are doing, the cost and quality of the providers that are in your network and who they're seeing for cancer care services?
So that sounds like personal information that I shouldn't have access to, or am I missing something?
No, it's really just getting, because, I think I've heard many times, and my boss says it best, gone are the times when you can play golf without a scorecard. So,
It depends on who you play golf with.
That's right. Yeah, we know that. Yeah, so I think it's really important to know, so my advice would be with these questions would be, you've really got to understand what the strategy is and develop a strategy to work with those to manage your cancer claims or to manage your cancer spend. What the site of services are. They hospital outpatient departments? Are they independent practices? Are they academic centers who's seeing the bulk of your cancer care claims or your cancer care costs are coming from? What's the drug spend? How much specialty medications and infusion medications are coming in, and what is your current TPA doing about that? Are they siphoning off some of those drugs? One of the big issues, this is going to be a tangent, one of the issues we have with our commercial business and our network is that the majority of the oral prescriptions that we fill, we can't dispense those in our practice. And, we all have medically integrated pharmacies, and a medically integrated pharmacy is really one where the care team is involved daily managing that patient. Really eyes on the chart, eyes on the patient, the nursing staff, the pharmacy staff, the doctor, the PAs, NPs, and medical assistants all are working together to provide the highest quality, most cost-effective care for those patients. But when you have an oral prescription that gets pulled out of that practice to be filled by the insurance-owned specialty pharmacy or the PBM that's located states away, it just makes it harder to manage those patients. So you can look at, are they progressing in their disease? Are they, finding out that they need a reduction in therapy for a minute, a little lower dose to maybe manage some medications? So those are the types of things you need to start looking at in terms of where your claims are going, who's managing your cancer business, and then also ensuring that you can measure some of the quality aspects and some of the provider rate, the provider information and the provider quality that you can get, either with the practice, monitoring that, giving you reports, or relying on someone like the National Cancer Treatment Alliance to provide that information back to an employer. So I think it's really diving into those claims and diving into your costs and really finding out what it is. But I think you really have to really be serious about it. You really have to realize that this is a huge cost for an employer, a burden for patients, a burden for employees, and it can be managed better and managed well.
Interesting. So, we do have a team that obviously we rely on to deal with this, and primarily it's our chief of people. And I know that our CFO is involved, but I don't know that they're involved to that extent, or that it's frankly even worth their time. Now, I do know what we spend on healthcare, and as I said, we have about 10,000 employees on plan. We're spending somewhere between 150 million and 180 million a year. What do you think the opportunity is if we're not doing this now? Can you give me an estimate of how much money we might be able to save?
Depending on where the sites of service are, you could save upwards of 15 to 20%, sometimes higher, depending on if you're really seeing some high outpatient costs, particularly from the hospital side. The physician practice on average, and we use Medicare rates as a benchmark. The Medicare, the physician fee schedule is kind of the benchmark and an industry standard on where claims are based. So an independent physician office can charge anywhere 120 to 160% of Medicare on the physician fee schedule. We've seen claims and talked to brokers where, those fees are sometimes 800% of Medicare.
Wow.
Just incredible amounts of spending. And that's on the service side. And then on top of that, marking up the medications, 5 times the cost of those medications have. And that just doesn't happen in a physician's office. The way the reimbursement structure is, it's usually a percentage of the drug cost, and that's usually about somewhere between 4 to 6 to maybe 8%, which is a lot less than marking it up, 5 times.
Wow. So that sounds to me like there's potentially a lot of money there. And if I think about it, though, money is only part of the equation, right? The other side of the equation is quality. And I've heard stories, I don't know if any of this is founded or unfounded or true or not true, but I've heard stories where people were actually on chemotherapy medication, and after further review, second opinion, they shouldn't have been on that medication at all. Do you come across anything like that, or is that part of the process of what your team does?
Yeah, so I think we've been asked that question before, and we don't see that in our practices a lot. A lot of what we see are times when the patient does progress differently, their disease changes, their therapy changes, or they get, sometimes those can be interpreted as a second opinion. We do encourage second opinions. Many of our practices, in fact, all of them, have the ability to provide a second opinion, whether it's through an academic center or through some outside partnership, or just really talking to one of your colleagues who's an expert in that field. Our physicians are very, very focused on patient care and collaborating on collaborating on patient cases and where they want to make sure they've got a good outcome. But patients always and should take advantage of the ability to have a second opinion and do that. And that's very important. And I know that's important to the employers and important to the patients also. But what we also see is there's a huge advancement in precision medicine with the implementation of biomarker testing and utilizing biomarkers to specifically personalize that cancer care to a patient, to their specific cancer type, really, really focuses on those better outcomes with reduced risks and reduced adverse events. So I think you're seeing this transition come where, 15, 20 years ago, it was, kind of standard chemotherapy for a lung cancer patient or a breast cancer patient. Now those medications can be tailored to that individual patient. And our practices are really big into precision medicine and biomarker testing. And I know that's going to keep coming on. And I know one of the things, coming up that we'll probably get into is some of the gene therapies and CAR T therapies that are, hundreds of thousands, if not, millions of dollars that are coming up.
Yeah, that's well. Since we were on that topic, why don't we talk about that? So, I mean, that's a mind blower. But there are gene therapies for folks that don't know now that can, they can be in the millions. I had Renzo Lozati here from USRX Care. He's the CEO of the company, and they're a fiduciary PBM. And there's a drug called Strensiq out there that's $2 million a year per patient. He actually had a group that had not one, but two patients on this drug. And so, for anyone listening, like the idea of insurance is catastrophic protection from catastrophic potential loss, right?
Yep.
If you have a $1 or $2 million drug for one member on your plan, that alone can be a catastrophic financial loss. So how do you manage the cost on the back end if you're a CEO? And how are you looking at these drugs? Are they prescribed? I'm sure you work with many, many different practices, and you're relying on the expertise of the physicians and the oncologists in those practices to prescribe appropriately. Do you have any control over that, or do you curate the folks that you work with, or is it hey, if you're a practice that wants to engage our services, we're here to help you? How does that work?
It's kind of a combination of all the above. We're here to help them, here to make them understand how the process of getting a patient on a very targeted therapy works. There's all the testing that's done. The appropriate biomarker testing, imaging, pathology, all those things go into play. And then usually the diagnosis and all the information points into a certain drug that may work for that patient and their gene type. And then, the physicians then follow, pathways or NCCN guidelines or evidence-based care information that really targets down to where those patients are really focused on, and really those drugs are known to work. Now, paying for them, I know that's really, for some of those very expensive therapies, that's really, a lot of those things are still being determined. But for a lot of the precision medicine now, the Opdivos, the Keytrudas, and those things like that are pretty commonplace in a practice. Many of the practices are large enough, and I think the market has shifted where those drugs can be available. Again, they're targeted therapies. They're not the expense level of the other ones. But we have evidence-based guidelines in place, pathways, and other evidence-based care protocols to ensure that those patients are receiving the right medication for the right patient, for the right time, and the right location.
Very cool.
Yeah. Yeah, and then on the other thing we're doing on the cell and gene therapies, and again, this is not on the reimbursement side, but what we're trying to do is help with that cost. There's practices in our network where typically those CAR T therapies, for example, or some of the, new drugs coming out were only offered in the hospital setting. We're working with hospitals, to partner with them and then help those patients transition more into the outpatient center, the independent practice setting, where they can still be managed, where they can be in a lower cost setting, but still receive that high quality care and successful outcomes.
Yeah, it's mind boggling how costly cancer is to treat. When I think about, the cost of drugs, the cost of treatment, the cost of care, it's got to be one of the main drivers behind the inflation that we've seen in healthcare. Is there anything folks could do about it?
In terms of the spend, I think there are strategies you can look into. We've talked about some of them, really looking at the site of service, understanding where your claims are coming from, focused on the site of service, looking at people who can help you manage those, having a very effective navigation program in place, whether that's, through a point solution vendor that you offer as a benefit for your employees, or through the practices themselves. All the practices we work with have very sophisticated navigation platforms and support systems to make sure those patients are navigated through the system in the most, high quality, cost effective manner.
So the Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit Benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket cost for healthcare. Visit Benefixa.com today. Well, if I think about it, if I use like a major diagnostic exam, like a CAT scan or an MRI, CAT scan with contrast, something like that, those tests can be $5,000, $8,000 in a hospital setting, and the same exact test can be done at a freestanding clinic down the street for a fraction of that, a tenth of that, $500, $800.
Yeah.
So, and what I'm hearing that, kind of the same could apply to oncology if they're treated, by one of the practices that's engaged with you versus in a hospital setting.
It absolutely does. So cancer care works kind of the same way. Not only are the imaging services, less costly and still high quality, PET scans, CT scans, MRIs like you talked about, but also the infusion services. The drugs just aren't marked up. There's no facility fees with an independent practice. And the claims are much, much lower. I mean, like we talked about before, hundreds of percent versus, a small percentage of that, versus a physician office. So I think there's, the affordability, the accessibility, and the high quality care is really a great story that we're trying to tell in community oncology.
No doubt. Again, if I'm listening now and I'm a CEO or a CFO, I'm a numbers guy, and I hear this, that now is starting to paint a picture, right? Mm-hmm. Because we talked kind of in the beginning about there's an opportunity for an employer to actually manage this because healthcare is a supply chain, just like any other item that we procure or service that we procure. Typically, there's a supply chain that can be controlled and managed because you can't manage what you can't measure. Mm-hmm. But here, if we break down the claims bucket, and we know that 80 to 85% of the dollars spent are claims, and if we further now know that cancer is the biggest bucket in that claims bucket, then it might pay to engage services of an organization like yours to put eyes on it and determine if, you are procuring healthcare in the most prudent way possible. And as you know, Robert, with the passage of the CAA, employers now have a fiduciary obligation to ensure that the plan dollars that are being spent are spent wisely, particularly if they're accepting contributions from employees for the coverage. And so I don't think enough employers are in the know on that, that not only do they have a moral responsibility to their employees, but they have a fiduciary financial obligation to them as well. And I would think engaging services such as yours would certainly cast them in a good light in the event the DOL comes knocking.
Oh yeah, and that's absolutely true. And I know we've been trying to bring awareness to that. I know the business groups are bringing awareness about the CAA and the fiduciary responsibilities of the employers now, and really just finding independent practices and the most valued or the highest value site of service. Usually that's going to be an independent practice, whether it's in specialty care or primary care or others, or freestanding imaging centers. But all those activities and all that analysis and that effort really does help show, like you talked about to the DOL, that this employer really is looking out. So in case there is a question that comes up, the employer can say, no, we've looked at our claims, we're, looking at our site of service, we're renegotiating contracts. We really are starting to really get into the promoting transparency, of course, not only transparency from the PBM side and the insurer side, but, the law that was created back in 2021, I think it was, for the hospital transparency to come out. So many of our practices start to look at those reports, and many of the employers were encouraging to really use tools and really look at the information that's out there from hospitals in terms of what they're charging. And then you can take that information and make an educated decision on looking for different providers or different ways to help reduce and manage that spend you've got. because I think, if we don't do anything, I think healthcare, just general trend in healthcare costs is 8%. Oncology's, definitely part of that in terms of the pricing that comes on and the increased cost in terms of the treatments that are available with the technology advancing. So anything you can do to help bend that cost curve is really important. And I know there are partners, we're not to this point yet, but there are providers who are taking on risk. We're looking at the ways to do that. We're actually working with a health company right now on an advanced payment model where we will be sharing risk at some point in the future. Now, it's a step-by-step process to get there, to prove that this methodology works, because it's not something just an employer can do on their own. You have to bring in outside expertise to manage the risk in terms of oncology care.
Yeah.
It's very complicated. There's a lot of variables and a lot of ways you have to work these agreements out to make sure that it's a win-win for everybody.
Yeah, for sure. And, I think what many employers probably don't, kind of fully appreciate or understand about healthcare is, they have, unless you're a mega employer, you likely have stop-loss insurance, right? So you basically are on the hook for paying up to X dollar amount, 100,000, 200,000, 250,000 or more. And after that, if claims continue to pour in, then you have an insurance policy that's kind of backing you up. In a fully insured plan, they have reinsurance. All the giant insurance companies have reinsurance. So they're reinsuring their own risk. But as a self-funded employer, those are your dollars. And so if you have the ability now, using your services to dive in and say, well, looking at our claims experience, we have several employees going, through cancer treatment, and they're what we call super utilizers. They're our highest utilizers of healthcare, and they're costing the company millions of dollars. Well, if I think about what you said earlier, and if it's analogous to an MRI or a CAT scan, and now I have the ability with the proper guidance and help to reduce that cost from millions of dollars to a fraction of that, that seems to me to be a no-brainer, because healthcare is the number one SG&A expense. And I know with SG&A dollars, every dollar that I save drops directly to the bottom line. So that's a huge win for shareholders. And I don't think employers really fully kind of grasp that or appreciate that. Or maybe those tickets to the Masters tournament that the big box broker gives them is worth just kind of turning a blind eye to it. But what I would say is, fuck that. Manage this expense and buy your own goddamn Masters tickets.
That's right. Yeah, because there was a study done recently. I can't think of the name of the study off the top of my head, but they did compare hospital outpatient to pricing for infusion versus physician office space for infusion. And over the study period, employers could have saved almost $3 billion. And on the commercial side.
Wait, I'm sorry. Did you say $3 billion with a B?
$3 billion. It was a long study, I think a 5-year study. But just that price difference over 3 years just on the outpatient services, on the outpatient infused drugs, they could have saved that much money by looking at a lower cost setting.
That is absolutely insane. So how much is the actual cost of the drugs versus the money being made up and gobbled up by the middlemen and the PBMs that are in between? How much waste and, abuse do you think is in that one segment? Yeah,
and I know there's we've seen graphics from some of the pharma manufacturers where sometimes up to 60% of that prescription dollar. So every dollar that's spent on a drug to develop it, to market it, and everything like that, only 60% of that is taken up by middlemen, by rebates to PBMs, to brokers, back to the wholesaler, to everybody. So everybody takes a little piece of that. And really on that whole spectrum, then they have to increase their cost in other areas, on other drugs and other medications to make that huge discount up. And I know a majority of that's going on right now. There's a large focus. I know there's a couple legislative pieces on PBMs, really looking at transparency. But also another one is the 340B program, where insurers have to, where pharmaceutical manufacturers have to offer that drug to a 340B entity, sell that drug at 40 to 50, sometimes 60% discount, and then that entity, the 340B institution, usually a large not-for-profit health system, can sell those medications to an employer at face value, and sometimes 400 or 500% on top of that. We have a study we did that shows, on a Herceptin vial, a physician office makes about $1,700 on that, that whole transaction for a course of therapy, where a 340B entity can make almost $200,000 on that same drug.
Oh my God.
So
That's
it's
crazy.
astronomical.
Would you call it Herceptin?
Herceptin. It's an infused medication.
And so, if I'm an employer and if I'm an employer and I'm paying like 200x what I should, if I'm not minding the hen house, I don't know that this is going on, right? I'm getting these increases year over year, but I really can't put my finger on it and pinpoint it. But what I'm hearing is your organization helps kind of find where the dead bodies are so that an employer at least knows, hey, here's where the overspend is. Here's an opportunity to fix it. Do you do any exercises like that with your members? Is that kind of part of one of the perks or the benefits of membership in your organization? Is that something that you would do with a prospective employer if they were looking at joining your organization? How does that all work? Yeah,
it kind of depends on the relationship. We've worked with brokers to look at different case studies that have been scrubbed of any personal health information. And then it's, that employer or that advisor working with that employer. We've had some employers come directly, but one of the challenges is you've got to make sure that that's very sensitive information so that you're not sharing any personally identified information, that you've got appropriate access to those claims. And I know those are things that sometimes employers can't get. Even though they might be self-insured, sometimes they struggle getting their own claims information back from their TPA or their advisor, who for some reason, doesn't allow access to that. But the most important thing is to make sure you have access.
There are reasons that they're not getting access to that. Let's not even think or pretend that we don't know the reasons.
Yeah.
The reasons are, they're protecting their own best interests.
Yeah.
And, if they're giving that information over freely, well, then there's an opportunity to actually inspect what you expect. And these entities don't want that going on.
Yeah, so I think that's really key, is to making sure you have access to the data, that you can bring in the appropriate expert, which the National Cancer Treatment Alliance can help with that. But just making sure that you can analyze those claims and look at it. I met with an employer, a few years ago, a very small employer from the Midwest, had, I think, 100 employees, and basically contacted me to say, I've had 3 cancer claims, and I've literally blown through all my stop loss. They're getting lasered out, which is a term I learned back then. Lasered out of the plan, but I'm on the hook for all that now, and I got to pay that. And he goes, I don't understand why these claims are so expensive. And the first question I asked is, do you know where they're coming from? And he said, no. Let me get back to you. So a few weeks later, after he finally figured out and got the data, he came back and said they were all being seen in hospital settings. And the frustrating thing was we had independent oncology practices in the same market. So we introduced him to those practices. They developed a relationship. We didn't get involved in the contracting piece at that point because we weren't as far along as we are now. But those are the types of things and, real life things that can happen. You don't think about it until now you've got a problem.
Yeah. And so for those, who might not know, Robert is talking about, he said laser, laser.
Laser.
So the laser is basically just a number, right? And if you're an employer and you are self-funded and you have a stop-loss policy, and your policy, let's say, has a $200,000 spec, that means that every belly button, every person on that plan, you're responsible for the first $200,000. So a large employer might have a spec of that or more. A smaller employer would have a much lower spec, say $25,000 as opposed to $200,000. But in the case of someone that is determined to be high risk, the actuaries will look at it and they'll say, we don't want to accept $250,000 worth of risk on this individual. they're going to get lasered. And so when they're lasered, the employer might now be responsible for $750,000, and then the stop loss would kick in after that. And so that's how that all works. But it's just crazy to me that left unmanaged, this is what's going on in the plan.
Yep. And you really have to be on top of that and look at the healthcare trends you've got. I know there's a lot of focus and a lot of discussion on the GLP-1s, the weight loss drugs, which again, those can be very beneficial in terms of reducing obesity, reducing diabetes and other cardiovascular diseases, and also the incidence of cancer. But I think the thing that you have to remember is there's still cancer is becoming a much more chronic disease. The medications that are out there now and the treatments that are available can really help with survivability and help very, very positive outcomes, get employees back to work. But they are, costly medications, and they need costly treatments and a costly diagnosis that really has to be managed effectively. So if you're focusing a lot on weight, you also should take a look at the cancer spend you've got in your organization also.
Interesting. Yeah. Well, I think, just to level set, a lot of the problems with healthcare in the U.S. is really manageable by doing a better job of managing the food that we eat, the stuff that we drink, our environment, how we behave. It's only, and of course there are exceptions to this, right? There's plenty of cancers where the origin is kind of quote unquote unknown, or there's a history of it in the family, and there you can make a direct link, genetically. But I do think by and large that we all need to do a better job taking care of ourselves from the get-go. And you make an interesting point, drawing kind of an analogy between obesity and cancer, because lots of folks that are diagnosed with cancer are suffering from other comorbidities, obesity being one of them. So I think first and foremost, if you can avoid, it's hard to say avoid getting cancer, right? Because how the hell do you do how the hell do you do that, right? And no one has a magic wand and can just make it instantly go away. But I do think if we look at, the numbers and the statistics, and we put our, science and math caps on, we look at the population of this planet, how is it that we're spending far more than any other nation on Earth? And our life expectancy is 5, 6, 7 years, trending in that direction, less than in other, parts of the world. Yeah. And I think a big piece of that is lifestyle. But at the end of the day, I could talk about that until I'm blue in the face. One of the hardest things to change is culture and the way that people behave. And, I could tell you I'm part of the problem. Like I've eaten too much and drank too much for far too long. And I'm trying to get a handle on that at this point. And I think I'm on the right path, but it's so hard because pizza is delicious and tequila is delicious.
I love them both.
And so, at the end of the day, though, it's that stuff that I think is killing us. And if now you're at the point, though, where there is a diagnosis, God forbid, where do I do? How do I manage this? Where do I turn? I don't think the answer is to a traditional healthcare plan where you're kind of picking a provider out of a network like a box of chocolates and hoping for a great outcome. So if an employer is listening to this, an HR, head of HR, head of people, CFO, and they're looking at this and they're hearing it. They're not just listening at it or listening to it or looking at us, but they're hearing us. And they say, well, based on what I'm hearing, there's absolutely an opportunity to move the needle in terms of dollars. And that's intriguing. But I think even far more than that, if folks really have their heads screwed on straight, the bigger picture is, how do our people benefit? And I guess maybe you can elaborate on that. I don't know if you have any stories to share of, how one of the people that are part of one of the teams that are part of your coalition, one of the practices, actually made a meaningful difference to the health or quality of someone's life.
Oh, there's just countless stories of that, where patients come in, they have an advanced diagnosis sometimes, or sometimes just any diagnosis. And, finding where you can find affordable, accessible, and high quality healthcare. So in terms of the accessibility, making sure that we have access to same day appointments or appointments within 24 hours for new patients. Because when that diagnosis hits, it's important to really connect with that patient as soon as possible. So we want to reach out to patients and make sure we're connecting with those patients and getting those referrals and getting them seen in the office as quick as possible to start that treatment plan to help reduce that anxiety. And then in terms of the affordability, of course, working with patients, the number one complaint or the number one issue in terms of working with patients is really the affordability of the medications and affordability of some of the services. So a lot of our practices have their own foundations in place, work a lot with outside foundations to look for funds, get a lot of manufacturer support for those copay assistance programs and things of that nature. And then also making sure that you've got adequate support. So the practices have, many times really supporting those patients, survivability programs they put in place where they stay connected with those patients and stay connected with them. But there's, countless stories where patients have come in and really, felt like a number at another outside location and come into a practice where the care is personal, the care is accessible, and it's really high quality.
Yeah, that's huge, because I've often said, whatever the condition is, but certainly cancer, it's not just the patient that's going through it. It's the patient and everyone that's connected to the patient. It's all of their loved ones. And sometimes the patient isn't they're not the best person to really navigate this on their own. They've just been, maybe, God forbid, handed, a death sentence, and it's just a matter of time. But in the best case scenario, cancer is no longer a death sentence. And so it's okay, what are we going to do to play offense and tackle this and give ourselves the best chance that we can at beating this thing? Sometimes, it is the patient that's best equipped to make that decision on their own. But I think oftentimes it's a little bit of a consensus, and it's the spouse and maybe someone else in the family that has a medical background. I don't think the answer is to ask Siri or Google, although ChatGPT is getting pretty scary right now. But the reality is, I think that, just having a hub, if you will, where employees and members can go for guidance, for counsel, for advice. Am I taking the right drugs? Is this the right surgeon, for the job? Can you help me, navigate? Is there a path to a patient's assistance program that they probably never heard of before, but which basically is a federally funded program that will get them the drug for free, get the employer the drug for free, so that there's absolutely zero cost to the organization or the member. Those opportunities exist. But if you're not in the know and you don't know how to navigate the system and ask the right questions, well, that's going to be a rough road for the patient, for the members, and for the plan. So let me ask you this. What do you think when you look at the future, and you mentioned, the incredible, work that's being done on the tech side of the business and gene therapy and all of the innovation that's going on right now within healthcare. What do you think the future of cancer care looks like?
I think when we're going to the future, we're going to have to rely a lot more on navigation programs, really getting those patients, because cancer care is complicated. And the providers we work with, the physician is the quarterback of the care team, including the patient, including the nurses and everybody we talked about. As we are moving forward with the shortage of oncologists looming, 2,300 oncologists short by the year 2030, that's pretty significant. So those patients and those physicians are going to need a lot more support to help manage those patients and make sure they're getting the appropriate therapy. So those navigation programs can help guide patients to the right test, ensure those patients are getting the most appropriate treatment, and finding out, like you talked about, where there's questions. And a lot of the practices do that. I mean, we always ask the patients, call us first. That's the thing we always tell patients, no matter what the question, call us first. we'll navigate you through the program. We'll navigate you through the process. We'll answer any questions, help find resources to get you set up with, transportation, with rent assistance or anything like that. But practices are getting busy also. So now you've got outside companies coming in to help assist those practices and help assist those employers with navigation programs. So I think you're going to see a lot more emphasis on navigation programs to help save some of those costs and help get those patients into the appropriate setting, and really a lot more targeted therapies. There's a lot of biomarker testing out there. A lot of biomarkers are not expensive, in terms of some may be as high as $5,000, but some a lot less, $1,000, $1,200. And that's an appropriate amount of money to spend to ensure that a $500,000 therapy is going to be effective and is going to work.
Yeah.
So the return on investment there. So a lot more focus on that. The jury's still out on AI and how that's going to help with cancer care in the future. There's a lot of work being done on supporting diagnoses. I know there's been a lot of work on the EHR side in terms of helping physicians be more productive in terms of the AI tool actually transcribing some of the notes. So really a physician can spend more face time with a patient instead of staring at a computer, typing in notes and working on that. So there are some benefits to that.
Yeah.
And then in terms of, helping ensure the treatment algorithm is correct and appropriate, and not really to usurp the physician's decision, but to support it and maybe present some different options that may be appropriate for that patient, and then picking the best one, ensuring that it's really the targeted therapy that's going to work.
Yeah, every once in a while you hear, there's a soundbite or a teaser on the news, cancer breakthrough, discovery, found. This could be the end of cancer. Do you ever think we'll get to a place where there's actually a cure for this horrible disease?
I think there could be for certain cancer types. I think there could be for certain cancer types, but for others, it's just going to be a lot more challenging and take a lot more time to do that. But I do think at some point, some of the cancers are going to be curable.
Yeah. Well, let's hope for that.
Yeah,
for sure. So I know NCTA is growing, right? And I think you mentioned an event like Payer Exchange Summit.
Yeah.
So tell us a little bit about that. What is that?
Yeah. So every year we host a meeting, and it's in the fall. This year it's in September in DC, or in the Washington, D.C. area. And it's called the Payer Exchange Summit. And it's really promoted by our parent organization, the Community Oncology Alliance. And so we put that on, and it's really focused on bringing employers and independent practices together, purchasers of healthcare, brokers, benefit advisors, consultants, to really talk about the business of oncology. So it's a day-and-a-half setting, and it's been very effective. It was one of the catalysts for launching the National Cancer Treatment Alliance when we first started working with employers way back, in the early, 2015, 2010, things like that we've been doing. So it's really been a catalyst for that, but it's really an opportunity to focus on the business of oncology and provide real solutions and help, make real advances in terms of making cancer care affordable, accessible, and making sure those high quality outcomes are still there.
And so who should look to attend an event like that? Would an employer, that's interested in this, think about attending? And is there a particular size organization that, your services are appropriate for? Where's kind of the starting point in your view?
I think the starting point is just any employer. I mean, we've got employers who are very, very small, just a couple of employees who really see our services in our clinics, and all the way to larger organizations. So it's really appropriate for an employer of any size who wants to learn more about the business of healthcare, or the business of cancer care.
Interesting. And so they could go down and attend, and you have employers attending, or is it really more focused on the practices that are part of your group?
No, we are really pushing to get employers to attend. So I think more of about 25 to 30% of our audience last year was employers, business groups, insurance consultants, and benefit advisors. And we want to see that grow. We really ask that each of our, if for every provider that comes, we want to make sure they have an employer match, an employer to work with. So it's been a really good, it's been a really great conference, and I think this year, we're expecting a few hundred people to participate.
Cool. So we can definitely get it into the show notes. So the folks want a link out to the conference. We'll get that in there. How do people find and connect with you? What's the easiest way to do that?
Actually, the best way to get in touch with us is really through our website, nctacancer.com. So we've got the ability for you to put in your information to get on our newsletter, or also for us to reach out and contact you. So the best way is through our website at nctacancer.com.
Okay, excellent. And so I guess if you could change just one thing about healthcare, and in particular about the way that employers now are managing healthcare, particularly with respect to cancer, what would you change?
I think I would change their awareness of the independent community oncology practices. You know, one thing I've learned going through this organization, it is a competitive business. There's a lot of hospital and health systems who are very progressive and very competitive when it comes to oncology services. They have a lot more resources than in oncology practices, but that's what we're there to help provide some of those resources, some of that information to help connect those independent practices with employers. So I think it's being open to listening and hearing and understanding the independent community oncology landscape.
Right on. Well, there you have it, ladies and gentlemen. Robert Baird, it's been a pleasure. Thank you for joining us. Thank you for enlightening us. And I don't know about you folks, but I learned a lot today. So until next time, peace and love always. Take care. We'll see you on the next one.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.